health crisis accelerating the digital transformation of health system. To answer this very, very serious question, we have the Minister of Health of Burkina Faso, Léonie, Claudine, Lougue, Sorgho. Thank you so much for having traveled complicated traveling conditions just to come to see us at the foundation of Pierre Fabre in Lavore in France. Please join us. Then Professor Antoine Geissbuhler, who's a Chief Medical Officer, e-health, Telemedicine in Geneva, coming from Switzerland. Please join us. Thank you. You're also a director and of the French-speaking African Network. And Florence Gaudry-Perkins, who is here, third seat. Please keep the distance, social distancing. So you founded the Digital Health Partnerships. You are a consultant for the governments, also in e-health, and also with us, connected from the States, from Atlanta, the Dr. Carl Kinkade, who is an expert at the Centers for Disease Control and Prevention. Federal agency in the U.S., has had a long international experience and career in the field in Africa, in Asia, in Middle East. So thank you so much for being connected from Atlanta in the United States. So first question for our Minister of Health. What is your feeling regarding the questions? You have a microphone if you want to. I'm going to remove my mask because, you know, I won't be able to feel free to answer your question. Okay, so we saw that in Burkina Faso, you have a tool to get data in health. In addition to this tool, that should help you better manage your health crisis. What do you feel? Do you feel that there's, I would say, a speeding up of all these tools? Thank you. Thank you for inviting me, giving me the honor of kicking off this roundtable. Now, the government in my country has become more digital and dematerialization of the data. And that has been the case for some years. And I would say the major application is what we call the concentration of data from the districts. Because firstly, I need to maybe describe how we organize our healthcare. It's 3 levels. There are primary care, secondary care, and tertiary care. And then we have a district-like organization and central. So we have 70 districts in Burkina Faso. And the data from the districts are generated from baseline, because we also have health caregivers who live in the communities, and they can manage the essential problems. So all this data is then sent with, so this is going to be sent to centralized, what we call DH2LT, so that is to say District Health Information Systems, and so on. That's the acronym. Anyhow, level 1, level 2, and so on. And so thanks to that, we're able to centralize all the data. And having what we call a statistics register, and this is a good application with the help of partners. And when we treated children under the age of 5, now when we decided to give free care for these children, so we obtained the data to show how effective that was for young children. And then, second part, the pandemics that of course came and speeded up the situation, but we were already there doing that in the e-health. And with Professor, we developed the the e-health register. So what you are saying is that you said we already had a strategy in e-health, whether you are getting feedback or sharing feedback with young children, because that is one of your priorities. So in the situation of a pandemic, we speak of COVID now, but unfortunately there were other pandemics. For us, for you as a minister, how do these digital tools have made your decisions easier? Did they change your work as compared to 10 years ago? Thank you for this question. In Burkina Faso, we have several challenges. Security is number one. The fact of having data means that we can continue giving care in displaced population. Because if you have a terrorist attack, then we have populations that are displaced, and we can follow these populations thanks to digital data. And so this is, again, thanks to the application of CDC Africa and Atlanta. And so we were able to keep a social link. And social partners had decided to keep the data. Now with tablets, thanks to the help of all these partners, unfortunately I cannot name all of them, but the health agency has generated some data that we could report in DHT2. So that was a big help to be able to cope with some challenges, but also help us make the decisions. What kind of decisions? Well, monitoring unexpected events. Imagine, if you have unexpected events, the data can help us detect this on time. By this doing so, we can investigate at a timely manner. Whereas before, it was a weekly report, so that means that you needed to wait for a week. Today, it's real-time reaction. Of course, there's the problem of continuous connection, but we also use text messages thanks to the mobile phones. We can use the text messages so that we can have a day-to-day updated data. Because when it comes to health, the decision is essential, and that's how you can save life. Yes, if you master time, you master a crisis, as we say, says the journalist. Okay, Antoine, the COVID crisis obviously has had a speeding up effect in your own facility. Yes, well, in my center, overnight, we saw that digital played a strong role. We were treating COVID patients, but not only. So overnight, we have decided to deploy 400 telemedicine stations. 10 days, you did in your hospital 400 posts of telemedicine for the doctors. Yes, so that they can continue follow their patients. Patients for whom they couldn't come to the hospital. So you were able to treat the COVID patients. It's a crisis, and at the same time, thanks to telemedicine, you were able to continue working almost normally. Well, for chronic outpatients, yes, it was a major plus. How many teleconsultations did you perform? Do you have figures? Well, several thousands. That was done during the 4 months, the peak, and then gradually things went back to normal, and then preparing for the second wave that is happening. And so maybe that will mean that we will be under more stress and better understand what is the role of these technologies that we have been using for some years now. But in countries with low distance, we're not that important, but now it is because of the current health situation. But of course, mindsets are changing. So suddenly our doctors saying that there are some consultations that they can do just as well. Instead of asking the patients to come to the hospital. We are having an aging population. I think it's a way of protecting and having better quality care. So I hear a lot in what you said. Firstly, the habits of telemedicine we saw now with Burkina Faso. And then secondly, you are not taken by surprise because you're able to deploy 400 stations. So in other words, you are able to continue working almost normally. It's impossible because doctors accept this digital tool. Can you tell us a little bit more? Up until now, we saw that only a few of doctors were fans of this, but not that many. Telemedicine, they were afraid of that. They didn't want that. However, with the crisis, we are intensifying this use, what we call a mass use, and everybody has to accept it. Everybody has to sign up for telemedicine. So how do you explain that they've accepted it? Well, there was a couple of weeks where there was not any other option. It was the only way. So, you wouldn't even think, do I need it? Do I want it? And so on. No longer questions because there was no other alternative. So the fact of being, faced with that, and so it's true, they were obstacles because they were concerns, but clearly we saw that for some doctors, they weren't really happy about it. But then clearly they realized that these tools have deserved to be used. Because, and it's not just during the COVID, it's even beyond. One example, a regular follow-up of diabetes patients that normally have to come to the hospital. It's not easy. They have to travel from where they are. They can't really walk properly, whereas they could also use these tools and then maybe have more frequent visits, consultations to have a better home care. Another way was to say having caregivers that used to go to the home, having quick access to experts or home nurses that could maybe call ER doctors and avoid having these patients come to the hospital in intensive care, because a lot of times you can find solutions at home, which was good for the patient, for the doctors. And so we were, in fact, with these tools, we are more effective, and the entire health system becomes more effective. These tools, do they change the relationship between the doctor and the caregiver? And so on. This morning we said that one of the challenges is to keep the patient centric. The patient has to be proactive, giving information on the disease, and so we are part of the medical approach. Do you see a change, a cultural change? Yes, we see it, but it's nothing new. The patients are now more empowered, I would say, and then for the past 2-3 years we see that patients want to be listened to and even proactive. So it's no longer a process that is patient-centric. It's really a team that really includes the patients, the relatives, and so we have a team that really works hand in hand. So it's very different from saying it's patient-centric, but this has been the case for 10 years. Of course, it's going to be, I would say, fostered by digital, the fact that, in fact, patients can speak to one another, which is not always what, doctors like, but that's another problem. But anyhow, that's this ability to understand, to really embrace their own problem, and also having a more empowered, more proactive attitude. This is something that we see. I wouldn't say that the COVID today has changed that. The tools that we have were tools that we had that would get close to the typical consultation with virtual waiting rooms and so on, and that kind of duplicate what their professional lives were. But we do see, however, the fact that the patients are feeling more responsible, they are feeling more active, and this is definitely something that we have seen. And that also changes how we devise our tools, because part of the tools that used to be developed only for doctors or only for health professionals and hospital staff, now they have another version for patients, for caregivers, having access to this information. In 10 days, you said 400 stations. Because of a crisis, more digital way of working. Was this easier because you had already worked in e-health? Was it easier? Of course it was, because that was also what we talked about this morning. I said that a lot of countries from the south are experiencing a health crisis, and we've had that for years and years. And I think that even 20 years ago, we understood that these tools, digital tools, not to solve everything, but rather to really help between the big cities, the rural areas. These tools can really support the professionals where they are, thanks to digital. And in Mali, we saw that in other. In fact, you learned from your experience in Mali. Of course, what we also learned from African countries, the setting up of these tools is 20% of technology, and the percentage of technology goes down with. And 80%, it's more organization, understanding, embracement in the processes, also in the strategies, national strategies in health, and so on. So all this work has helped us, in fact, set up tools that work. And so when we deployed this in Geneva, in one of the richest cities in the world, we saw where the 4G wouldn't work, and the fact of having resilient tools being capable of, are easy to use by people who are not IT geeks, for example. So suddenly these tools are easy to deploy. So I would say we made the most of our 20 years of experience that we gained in Africa with telemedicine, and that really made the situation in crisis easier in Geneva. Yes, so making the most. Thank you. Now, you also talked about more and more use of digital. You had no choice during the crisis. Now, how is it today? Do you think that the habits are here to last? Well, during the summer, we went back to normal. I know that today we have a second wave, we have more COVID patients, elderly patients, so therefore risky patients. So we will have to face a second wave. So we've had time to prepare and think and anticipate. So these uses are going to evolve with the crisis. The fact of having had a test and tried situation, experimented other modes, that means that we no longer experience things differently. One of the things that have modified, I wanted to mention this because we talked about the challenges around data, to understand how much we needed to control our real-time data. And I'd like to thank the Burkina Faso collaboration, we have been able to work with the Ministry of Health on tablets, on follow-up consultations, children diseases. We have 2 million consultations, and we have been able to duplicate some techniques, AI, machine learning, identify. So the first thing that we have been able to identify is what are the caregivers that perform well, those not as well, and those who perform well can teach the others to use the system. Another thing that we have been able to deploy a couple of weeks ago, daily dashboards that inform the decision makers for health districts. So this experience, we have been able to symbolize it in what we call a 2.0 hospital, this ability in real time to say, where are the resources, how do we position the patients according to their contagious situation or vulnerable situation. Very interesting, because 20 years later, I see the fruits of my work, of what I learned in Africa. And I know that, during a crisis, these become essential. So clearly, it's a north-south learning.
Well, I'm listening to you. I'm fascinated by what you're saying, but I'm also surprised by the world in which we currently live. We do see that on the one hand, the United States and Guinea are working hand in hand, also Denmark. So we do see that collectively we have a development of such a tool. So it's not only a north-south relationship, but it's again a multilateral partnership. And again, what you're explaining from Geneva. So it's a changing paradigm. I think that we've witnessed it the last 20 years, right? Answer: well, yes. When we started, the expertise was in the north, and we would be transmitting that to the south, but then we realized that it was not true. If we want to make a difference, we have to have a sound knowledge of the grassroots level. We have to understand the social environment, the culture as well. And so when we have everybody around a virtual table, then everybody does contribute to the conversation, and this is the beauty of those networks. Yes, I would like now to address Carl Kinkade from Atlanta. You're an expert at the Center for Disease Control and Prevention. This is a federal agency. You also worked very much in the field. You observed how the Ebola crisis was managed. Now, have you seen a change in digital uses? Do you think that digital tools radically transform the healthcare systems? Do you have concrete examples that you experienced in the field?
Well, yes. I mean, I think there's an expectation that digital tools will be used. I think no one wants to go back to the days where everything's on paper and you're doing data entry on paper and then doing interventions with patients, to sort of get ahead of a response. My world is in first response with CDC, and like you had mentioned, I was in Liberia for Ebola. And in Liberia, the case bases were all case-based data, and it was all on paper, and it came in. But post-Ebola, as we started establishing or working with the Ministry of Health to establish their IDSR and then later EIDSR, the Integrated Disease Surveillance and Response, Liberia wanted to stay with case-based data. They didn't want to go back to aggregate data, and so their IDSR was set up for their 14 diseases. As case-based data, and initially was all in Excel, and realizing the sort of painful process that was, having, they wanted to go to EIDSR, and they've since established, at least in part of the country, it's still being rolled out, a real-time surveillance system from the health facility level up to the national level. I just moved back from there last year. I lived there for 3 years to help them recover from the outbreak. And I still remember the day the Director General for the National Public Health Institute of Liberia, he was in Beijing for meetings, and he received a text message in real time that there was a suspect Lassa fever case. And he talked about it for the next 6 months. And we said, that's the point. The point is that technology allows us to know what's going on in our communities better. They allow us to understand what the response needs to be. They allow us to adequately respond and prepare, and then craft that response in more real time. When I look back in 2008, I was in Myanmar after Cyclone Nargis to help with a rapid assessment with OCHA. We couldn't use digital devices. We used paper. And so, as you can imagine, out in the southern part of Myanmar, when it's still rainy and bad weather and a lot of destruction, you have teams on the ground collecting household surveys on paper, and they were hauled back to Yangon, where we did double data entry. And then, of course, in that process, you have to go back and fix errors, and all that has to come before you can even start that report to Geneva. And, fast forward to 2010, and Haiti, when I got to Haiti, OCHA, I came in, and some of the same people I was in Myanmar with were in Haiti. And they said, Carl, we want to do the same thing we did in Myanmar, but not on paper. And so back then we used PDAs, and we did the initial rapid assessment on PDAs. And that it eliminated that double data entry step. It eliminated errors. It made it more rapid, and then allowed leadership to get information they needed to make decisions more quickly. And so I think there's an expectation across the globe now that we're going to use technology. Yeah. And we're not going to, no one wants to do stuff on paper. Sometimes you have to, but the thought of filling a truck with paper and driving out to the field to collect responses is painful for everyone.
So we see with your examples, we see that the tools really help in saving time, also help in making decisions in a quicker, swifter way. This is very interesting in case of an acute crisis. Now, don't you think that there's also another type of change in the way those tools are being developed? We see that with the epilepsy project, where we have this collaboration between North and South. We also heard this project from Burkina Faso in Switzerland, where there were lessons learned from on both sides. Do you have the same observation? The fact that the South-North relationship is changing, is that crisis also changes the outlook that we have on our partners?
Well, I think that, that when people use technology, and of course, as a Liberian, as an example, donor organizations like Gates and others want to invest in technology-driven solutions, and that investment helps with that response. But then that investment lives on into the next steps of routine surveillance and active surveillance and integrated diagnostics through laboratory. And of course, response efforts and emergency operations centers. All this stuff is technology driven. You can not use it, and in parts of Liberia, as an example, where there's not data coverage, it still has to happen that way for part of the country. But as technology changes, infrastructure changes, that all, of course, changes. I think that there are differences, of course, between countries that have more infrastructure and more penetration of digital technology. If you look at South Korea versus Liberia, it's a different population where technology and smartphones and the like are throughout the society, and it's an expectation. Can you imagine South Korea agreeing to do anything on paper? Probably not. But at the same time, as I look at some of the response efforts in Africa, where a lot of time has been spent around infectious diseases and contact tracing and response efforts, in many ways, they've done better than the U.S. has done, for instance, because that's not what we deal with. U.S. tends to focus on chronic diseases, and infectious diseases are usually small clusters, occasional larger, E. coli or salmonella outbreak. But other than that, they're typically smaller, and and not something like we're experiencing right now. So in many ways, if you look at what Liberia has done post Ebola and currently during the Ebola response, in many ways they've done a better job than many of the other countries because so much time and effort by many partners supported them to get to where they're at.
Vous m'avez surpris lorsque l'on prépare.
When we prepared this roundtable, you said, well, my job is not to have something to do in Liberia in case of a pandemic. Could you please develop or elaborate on that?
Sure. I think, all of us love to work with our partners. And when you work a lot in a country, you, of course, establish strong connections to the people there and the organizations. And of course, I have many close Liberian friends, and I love working there. At the same time, if we're doing our jobs right as partners, then we work ourselves out of a job. You build that capacity in country to where Liberians are taking care of Liberia. Not Americans, not CDC, not WHO. That should be the goal. How do we build that capacity across the globe where countries can take care of themselves and there's sustainable solutions? I think it's always very easy for partners to come in and stand up a partner solution. And I think that's where we have to be careful. And I think that the more we work together and we collaborate across organizations, and we really focus on truly sustainable systems for the Ministry of Health, then we work ourselves out of a job, and that should be our goal.
C'est particulièrement intéressant ce que vous nous dites, plus nous
Yeah,
travaillons.
you're right. The more we work together, the more we're going to find solutions together. Now, when you think about the fears that there are currently vis-à-vis the United States, we know that there is quite a number of health data are hosted by Azure in the United States. And so we had this conversation with Morning around GAFAs. Should we leverage the tools like Facebook or other social networks just because they have this strong power and they are able to connect us to a number of people? Should we use the tools of WS, of Amazon? They also have face recognition. They have calculation speed that are a lot stronger than any state could ever have. But in a nutshell, what should be our attitude vis-à-vis the GAFAs and the United States at large?
Well, I think that we all know the power of the social network, social network and social media and the companies that make and host these services. And there's some very, very good tools there. I think that we all just have to be also cognizant that, that things happen, that there's always a potential that your data will leave. I remember, and I hate to go back to Liberia as an example, but one funny thing that happened toward the end of the response, as we were talking about how to move toward a cloud-hosted EIDSR, one of my colleagues in Liberia had commented that they didn't know if they were comfortable with hosting in the cloud. But throughout the response, they were backing up their Ebola data and emailing it through Gmail as a backup. And so I joked with them that you're already using cloud hosting, but in a very poor way. And so, you can be smart about your hosting. I think these companies are good companies. I think their intent is most of the time right. I think there are other stuff that happens. But I think that as long as you're smart about the way you use them and you're careful and cognizant of the risks, that you can do it. Now, we as CDC and the U.S. government, we have some AWS government services, but they're separate. They're separated from the other components of AWS. And that's the way you start to use these services in a smart way.
J'aimerais bien connaître votre opinion, Antoine Geissbuhler, sur ce
So
sujet.
we all realize here around this table that those tools, and especially during the crisis, are being more and more widely used. And those tools also open up new avenues for patients, but also healthcare providers. Now, again, most of those tools we're talking about are directly linked to one country, and we're talking here about the United States. So is it a source of concern? Answer. Well, those tools are designed in such a way that they can be rolled out very quickly the world over. So we're going to be pretty much challenged if we want to do just as good as they do or hardly as good as they do. So we need to find a way to have we need to find a way to use them while being cognizant of their risks as well. And so I concur with what Kinkade said. I think that the issue is not so much the companies which developed those tools, but rather a question of sovereignty over data, data protection, private life protection. And those are, rather the questions that we have to contend with. You have the Patriot Act, you have the Cloud Act, you have all those mechanisms that are at play, and the underlying question here is data sovereignty. Yeah, but on the other hand, you have a number of users saying that the GDPR, the European regulation, is also a hurdle in the use of the data that we collect. Well, you're right, but that GDPR was also a long time in the making, and there were many negotiations, and I'm under the impression that tools are being developed quicker than legislations. I think legislation will always be lagging behind, and we have to accept that. Now, when we have a consensus, when we have standards, for example, so GDPR, I think this is it really embodies a will from the population to strike the right balance between having access to data because it helps in solving data, but at the same time protecting those data so that each citizen is reassured on the fact that their private life is being protected. So we need to we should strive at striking that type of balance with the GAFAs and also the governments behind. This is complicated in the current context. We hope that things are going to make headways, but big entities like Europe have strong solutions or strong proposals to try and influence those discussions, but discussions will have to take place. I think, some people think that all data should remain in the country, should be controlled by the countries, but there are limitations, and there are good examples that were given by Carl. So there is no straightforward answer. We need to keep our values, the values of our society, and we need to, we're facing a number of dilemmas: public good, individual liberty of freedom, but also the interest of a wider community. This is nothing new. This is not something that was created by COVID. It existed before. So we need to recognize that, and we should try to be smart about that. Florence Perkins, you are the founder of a startup named Digital Health Partnerships. Do you also agree on the fact that health crises do accelerate digital transformation? Well, I think that there's a strong acceleration in the digital transformation in the health area. You have to know that the use of the internet was multiplied by 70% in the lockdown period. So this is no minor feat by the mobile providers or internet providers to contend with this very steep increase in internet usage. So of course it helped. It helped us to stay in contact, and it had a positive impact on digital health. And you cited a number of examples. Now the crisis, and I would like to talk about this because I think it was not discussed today. The crisis also highlighted the fact, the gaps and the differences in the different layers of society. And this is not a north-south problem, it's also a north-north problem. Of course, the problem is even more complex in countries with less revenues, but 3.6 billion citizens do not have access to the internet. So the COVID crisis also was a way to highlight those gaps, those differences. We knew that before, but I think that there was a collective recognition of that. Now, on digital transformation, Professor Geissbuhler also mentioned that there were changes in usage for healthcare providers, for patients as well. I also observed that with telemedicine, many legislations became less stringent during the crisis. In France, there were also the possibility to have telemedicine or teleconsultations to be paid for by the state insurance system. This is something completely new. I also recently read a survey in which they said that three-fourths of GPs in Europe agreed that digital tools were a lifeline in their daily life and really helped them contend with the crisis situation. Now, when it comes to data collection or access to data, I also have a number of colleagues saying that during the crisis there were more data exchanges than ever. So it really helped with that. It really helped with data circulation. Now, on telemedicine, as I said, this is an area which I know quite well. Hani Iskandar from the International Telecommunication Union talked about this morning. One of the first applications in the wide field of e-health were the digital tools. And there are a few figures that I would like to mention. Well, in France, at the beginning of March, we had about 10,000 e-consultations per week. At the end of March, we had 1 million teleconsultations per week. In China, Pinhang Good Doctor, it is a telemedicine service. Of course, we're talking about a scale which is huge, 200 million users in China because they have so many inhabitants. They had plus 900% of consultations between the beginning and the end of lockdown. In the United States, 11% would be using teleconsultation, 46% would use teleconsultation at the end of a crisis. So there's really a boom of those teleconsultations. Now, my question would be, is it going to be a durable phenomenon? Well, as Professor Geissbuhler said, well, those figures were reduced when the lockdown was eased or lifted. But I think it really changed the usage. I think it's a lasting change. And beyond that, and I wanted to concentrate on I think that telemedicine or e-health really depends on the rules and regulations that are implemented. Now, telemedicine, well, in our country, has to do with the right to write a prescription, to send a prescription. Is it possible to send a prescription via Gmail or Google Mail? And then in our country, we also have those questions with the state health insurance. Now, during this crisis, there were incredible side effects. In our country, in France, we were pretty much advanced when it comes to teleconsultation. Before the crisis, it was not possible for you to consult for the first time for one condition if you had not seen a doctor before for the same disease. Same thing in China. You had to see a doctor in person before you had a teleconsultation for follow-up, for example. So in a number of countries, those things were changed. This was the case in China, in France, in the United States as well. So I think that those changes in the rules are not going to go back to the situation pre-crisis. I think those are there to stay. So the thing is that you mentioned about telemedicine, e-health, whatever the name you want to give it. For a long time, we thought that it was a gimmick, that it was a gadget, that it was good for countries in the south because they have so little doctors. And so it was almost a source of contempt for GP in the north, where people would say, well, you know, you can't really have the right diagnosis through a screen. Now, what you're telling us is that the sanitary crisis completely changed and brushed aside all those criticisms. Well, it didn't completely brush aside those criticisms. Not everything can be performed remotely. However, there are more and more options available thanks to connected devices. You underlined the solution for diabetes, what you can do remotely when it comes to diabetes monitoring. I'm also familiar with the booth for telemedicine, where you have 15 connected devices and you can have an ECG, an EEG, and a number of tests. So there are a number of options available to monitor the vital signs and things. So there are still a number of hurdles, but telemedicine has made a lot of progress. Antoine Geissbuhler, again, I would like to ask this question. Do you think that health crises do accelerate digital transformation of health systems? In the past, those tools were considered as gadgets. They were not really considered real health tools. Don't you think that this has changed? Don't you think that now people are more aware that those are not gadgets, that things are lastingly changing, that there is a before COVID and after COVID? Well, you know, it's difficult to talk about a post-COVID situation because we're still pretty much in the middle of COVID crisis. But anyway, during the first lockdown period in France, there was a tenfold or 100-fold use of telemedicine during the first lockdown, and then it decreased, but then it's going up again. Now, what's interesting is that even in the well-off countries, the health system can be put under such a strain that we need to think about the whole system altogether and rethink the whole system altogether. So indeed, there was already a conversation in northern countries about aging population, about follow-up of elderly patients, etc., etc. And it's true that telemedicine, and this is what we did as well in Sahel countries when we started the RAFT network. We had a network of GPs, then nurses, then midwives. So you have a chain of community-based healthcare workers, and now we are able to provide care even in remote area when in the past you had to travel to the capital city. So this really changes the way we think in terms of how we organize the provision of care, also in rich countries. And I think this reflection was certainly sped up by the crisis. And those are, we had to ask ourselves questions that we never had to contend with in the past in northern countries, because we feared that a hospital would be saturated. Now, those are questions that we have to contend with on a daily basis in countries of the south. So again, digital tools are not here to replace a GP, are not going to replace them, but GPs are going to become augmented professionals because they're going to have more expertise, more information. They're going to have tools which are going to help inform their decision making. So I think those are those practices that are going to change. And also the viewpoint of our population. So we experienced a very stressful situation, and we need to, again, keep the learnings of this crisis to have a higher performance system. And I'm sure that digital tools to have a role to play. Now, I have the same question for Carl Kinkade. So Professor Geissbuhler here just said that there's a before and after COVID crisis. Do you think it's the same thing in the United States? Do you think that the crisis had you rethink the way your healthcare provision is being provided? Do you think that you can learn lessons from countries in the global south? Do you think that there's indeed a before and after COVID crisis?
Yeah, I think there's probably a lot of lessons learned, throughout this response. We probably know that local health departments, which is the strength of our public health system, needs to have this capacity. We know we need to have standards around data collection and what those processes are and reporting systems. So there's a lot of sort of tweaking as this response is going forward by both local, state, federal. With the U.S., even though we're a federal agency, our role is to support the states, and the state's role is to support the local health departments. But oftentimes, the local health departments have the least resources, and so it's important, when you look across these, that you address it uniformly. But just by the structure of our system, each local health department can kind of address it individually. And that makes it a bit of a challenge on how do you respond to something that's this national in scope, and then the reporting process. So we have ongoing national surveillance systems, of course, and some of those, of course, are infectious diseases. And those have been used for years, and they work. But we're also seeing that there are challenges to the process of doing widespread contact tracing and the tools and who's doing what and what are those standardized forms and et cetera. So I think in that respect, a lot of the countries, when you look across some of the other countries that are what they've done with technology, if I look at Uganda, they've done some amazing work around their national surveillance system and their ports of entry and their lab integration and the like. I just watched a presentation by Mozambique the other day where they have this ports of entry app where the people who are traveling go online and they register and they download the app, and then when they get a QR code back to them via their app, and then when they get to the border they bring up the code and it's scanned and their contact information is there. I think those processes can be used by everyone. It's irrelevant if we're America or Europe or Africa. Just that process of how do we make it the easiest for the end users, and that's the people, right? I mean, what can we do as organizations to help it not just from a data perspective easier for end users, but they get access to care and they get access to their own information and it's protected. I think all those are lessons we learn from each other.
Very last question. We also have many questions on the chat. We discussed very much of healthcare systems before, during, and after the crisis. Now, what about our patients? What about the users? Are we also asking them to change, to accompany somehow those new tools? Well, those new tools really helped with the empowerment of those patients. So to make them more responsible, to make them more proactive in their health. I think it's a major trend. So we're talking about shared decision-making, etc. And all those tools we're talking about do help in providing information, in providing good practices. There are also social networks and communities, and this really helped in breaking down this top-down connection that we used to have from the medical specialists to the patients. Now, we are conducting a reflection on how we create value. This is what we call the value-based healthcare. So this is a new metric that we didn't have before, and this is something that is more and more embedded in the way we organize our healthcare system. So yes, digital tools, I think, really helped with that, and the crisis really highlighted how communication tools, dematerialization tools, or tools which made it possible to do things remotely. So all those tools really opened up a number of avenues, and I think it's, again, it's a massive, major underlying trend which started maybe 10 years ago. Okay, thank you. That would be the concluding remarks of this roundtable. It was extremely rich, very interesting indeed. Now, I propose once again that we have a Q&A, a few minutes dedicated to a Q&A. There are also a number of questions on the internet. Now, a question for the Minister of Health from Burkina Faso. There's a question for Tidiane. I think that we can reduce the consequences in the delay with which we care for patients. Thank you very much. Well, digital tools, when it comes to public health, I think we're going to use them more and more. And what we need are data that are collected in real time. Now, we need to make a distinction in between groups. Of course, digital tools are not here to replace the medical doctors. Now, for chronic diseases, I think that those tools can help create the right relationship with patients and to save them a trip to the hospital. So for public health, I think we can't do without those tools anymore. However, we need to have a framework around data privacy. And again, I would like to congratulate 3 of my co-workers. They are working so that we receive data in real time and in order to inform our decision making. And again, we need to be able to pool those different data sources. We also need to be supported by all bodies for digital transformation, so it has to have a very good map of all available resources. Okay, so from what you're saying, I think the key word here is that we can't do without those tools now. Now, another question for yourself and for Carl Kinkade as well. So 2 territories with different infrastructures and different cultures. I have someone on the chat asking the following question. Now, health becomes more and more digital. Don't you think that access to the internet will become a prerequisite to be able to access to health? Well, there's indeed what we call this digital fracture, this digital divide. So we work on data collection so that we can inform our decision making. But as far as patients are concerned, again, digital tools are not here to replace healthcare professional. We work with Professor Geissbuhler, for example, on a radiology project. We have very few radiologists in our country, and so So we tried to develop a platform, we tried to develop tools that would help in the interpretation of X-rays, for example. So this is rather protective of our patients because those pictures were interpreted by real doctors. So then again, I don't think that access to the internet should be a prerequisite of access to health. Now, I would like to ask a question at the other end of the world, the United States. Do you also have this question in your healthcare system? Access to digital tools, access to the internet, don't you think it's going to be a prerequisite if you want to access care?
So I think it's a tricky question, right? So in the U.S., we have parts of the U.S. that don't have internet access. But it's even more than access to the internet from an infrastructure perspective. It's also a generational thing. So you have elderly populations that may not be comfortable with the internet or may not be comfortable with apps. And then you have the younger generation who expects that. If you send an 18-year-old to the doctor and ask them to fill out a pile of papers, they're not going to be happy. They want an app to fill out, and they want to submit it online before going. And that's sort of the expectation. Every time I run into a doctor's office and I fill out the same forms, and parts of the forms are the same information over and over and over, I keep thinking in my mind, what are we doing? And you go into a different office where it's a tablet, and you answer that question once, and it pre-populates those forms back on the back end of their system. That does many things, right? Number one, it makes a better experience for the patient. Number two, it has less errors. Number three, it's information in the system that the doctor and the leadership can see and respond to more readily and quickly. But you're always going to have some form of access to healthcare or infrastructure that doesn't allow it. So we have to expect that we will not have internet, or we will have people who don't use it. And so the system has to accommodate that. But I think with the younger generation coming up, and as infrastructure changes, that will change over time. And I know as I look back to Liberia example, if you're in Monrovia, there's decent data coverage. If you're out in the rural area, there's not. And so the expectations are different, right? And people in the rural communities go to the clinic and they get treatment directly. And people in Monrovia could do an app for at least a amount of pre-clinical information that could help serve their client, their experience at the clinic or hospital. So those are all, we all want to be digital. We have to realize that's not going to always happen, at least for not a while. And but it does make the system more fluid, and it actually improves probably care, and it improves the intervention and the patient experience.
Et donc pas seulement une fracture numérique, mais aussi une fracture générationnelle. D'autres questions ici?
Yeah, so you're right. There's also a generational divide here. Now, there are a few more questions here in the room. So again, we can't give you the microphone, so you need to speak in the microphone, and the lady is holding it for you. Now, this is about the digital divide or fracture. I'm from Senegal. I am the founder of a startup, and we have to do, and we tackle the financial access to health. In Senegal, there's one doctor for 10,000 inhabitants. Very recently, a friend of mine died. She was 36 of age. She has a breast cancer, and she couldn't find a doctor in due time to have a diagnosis. So she entered the health system at too late of a stage. Today, when you want to know when a drug will be available, well, in our country, WhatsApp is more and more the place to be. Today data is the new oil. Today, poorer citizens can afford to provide information or to provide their health data. So all the questions that we are hearing here are, of course, very good, but we would love to be able to have a remote teleconsultation in our country. We are ready to send a prescription to a doctor, and we would like to have our drugs being delivered to our home because, again, we are in a state of curfew in Senegal at the moment. So the situation is such that we send the prescription via WhatsApp, then we pay with Orange money. And again, I'm not here to advocate for them, but you know, the situation is such in Senegal at the moment. And I think that, you know, when you talk about this digital gap or digital divide, I think that there's not such a gap in Africa. You know that a number of GAFA are ready to provide internet free of charge to all African citizens. Every time you go to Africa in a number of countries, you have more and more offers whereby you have free data or free gigabytes that are being offered to you. Our population is very young. 70% of the population has a smartphone. And I think that this younger generation is ready and more than ready for remote consultation. Now, Antoine Geissbuhler, two things from everything that we heard: the importance of social networks, for example, WhatsApp, and the generational thing. So obviously, those GAFA once again need to be integrated in our healthcare systems, right? Well, social networks, yes, we'll need to integrate them because they are creating a community. So it's true that the social networks at the time being are being created and operated by GAFAs, but the future will tell whether new networks will be created. In our hospitals, we do have in-house social networks, if you will. The Tele-Expertise network that we developed in the Sahel countries are a sort of WhatsApp, and data are not hosted in vulnerable places. But anyway, about this digital gap or this digital divide, this is, of course, a major theme and a major topic. This digital divide has different dimensions: access to infrastructures, differences in between generations, and those differences are here to stay. What we experienced during the health crisis, we did see new forms of solidarity. And I would like to give you an example. In a hospital, we had elderly patients in a hospital, and they didn't have a smartphone. And overnight, they were diagnosed as infectious, and they were not able to see their peers, their children. And so very quickly, there were volunteers. Most of the time, those were medicine students or administrative workers. They were ready to lend their tablets and to help those elderly people to, use FaceTime and say goodbye sometimes in some situations to their children or grandchildren or what have you. So, I don't think that the question of internet access will be resolved overnight. There will be access issues, but we need to also create new human solidarities, new behaviors that help in compensating for this digital divide. Well, I think that this digital differences, of course you're right, but I don't think that the digital divide will stay forever. In a matter of 5 years, the improvements have been very strong. As you said, 75% of Senegal population are connected and have smartphones. So what you're lacking is not so much smartphones, but telemedicine available in Senegal. Telemedicine in the world is one of my area of interest. Telemedicine has been around for quite a while, and it's a lot less complex than AI or algorithms. And actually, you would be surprised by the fact that there are very few countries proposing e-health services and teleconsultation. There are maybe a dozen countries with a proper telemedicine network, and I know for a fact that Senegal is not amongst those 10 or 12 countries. So there's still a lot of work in the tools. Beyond the digital divide, we still need the proper tools. So at the end of the afternoon, we do see that those tools can help bring people together. And before we conclude, we're going to go back to Lomé in Togo. Maybe they have a few questions that I'd like to ask.
Lomé, au Togo, on retrouve...
In Togo, we find the students in the campus. What are your reactions after this roundtable? Lots of exchanges and discussions. Thank you so much for this wonderful roundtable and about telemedicine. And we feel that this is really going to encourage us continue what we do with telemedicine. And also, some questions that have been asked really answers our own questions. So thank you everyone for giving us the floor.
Moi, c'est M. Batasangacha, doctorat en médecine. Nous tenons d'abord à dire merci à la Fondation Fac pour la lumière qu'elle apporte en matière de la e-santé à travers cette conférence. Nous avons essentiellement deux questions, dont la première est: quelle est la considération éthique et légale de
So thank you, Pierre Fabre, the foundation. And the cooperation is going to be essential, especially in our activities. Thank you. So two questions also that we wanted to ask, how the cooperation, what can we do? Okay, so we will ask the questions directly. So the question of cooperation and responsibility. So, of course, no one had, everybody had distance advice. Well, yes, responsibility. I think there's two questions. Questions of cooperation, prescription, the value of a prescription via telemedicine. I think the ethical question is, if I make a decision based on a less complete information as compared to a face-to-face interview with a patient. So there are limitations to what I can measure, see, perceive, understand, because I only have a screen as a contact. Am I sufficiently, I would say, aware of my reasoning, my decisions, so that I can take full responsibility for it? I think that's the essential question. I think that what we see is that indeed we can do much more than what we think with these tools, even if there are some limitations. I think that it's about, it's the doctor's choice. Does he or she think that he is doing everything to benefit the patient and he has all the information needed? What about a chatbot? A first examination, level 1 of questions or check? Well, we're far from having something that really has this ability ability to understand and not just sort out. So the chatbot is good for sorting out. Of course, we're experimenting and testing work. We're also trying to see the translation, automated translations. There are some promising applications, and especially in the area of medical consultation, the field of possibilities. So you need to have a fine-tuned understanding what I call a strong intelligence. I think that for the time being, we're far from it. I think that you have to stay humble with these tools. They are very good to have specific tasks, analyze an ECG or a brain scan or derm picture, sort out, orientation for very specific tasks. That is good. We have nice progress on that. Now, when it comes to a more clinical, complex situation, I find that this is not something that the current tools can do. In the same way as how this first decision-making step, we see an old doctor that sees the patient coming to the waiting room and already has an idea of the diagnosis. All this phase, seeing the patient walking, we're not even aware, it's unconscious. This is something that is very important to recognize and acknowledge. And when we do telemedicine, we have to make sure that we get as many elements as possible to make sure that these mechanisms do work, because that is not what a machine can do. So I'm sorry I gave a very long answer to a short question. Then the responsibilities. There are some rules, regulations in each country, but again, we have to make sure that the person who prescribes is a qualified person for doing so. So today we have some identification or authentication, if you like, so that we can really have e-prescription. I think, there's no reason for not doing that.